Good afternoon. It's a privilege to host a live session on behalf of Fortis Hospitals India. The topic up for discussion is one of great interest. How has advanced technology improved cancer care so that each individual patient's outcome is enhanced? I have with me today thought leaders, senior clinicians from across the Fortis network in the country, each a definitive leader in the chosen specialty. My name is Dr. Mohan Keshavamurthy. I'm Principal Director for Renal Sciences based out of Fortis, Bangalore. I have with me today the privilege of introducing Dr. Pradeep Jain, Principal Director, GI Services, Fortis Shalimar Bagh, Dr. Vedant Kabra, Principal Director, Surgical Oncology, Fortis Memorial Research Institute, Gurugram, Dr. Sandeep Vaidya, Executive Director, Neurosurgery and Gamma Knife Services, FMRI, Gurugram, Dr. Anil Kumar Anand, Senior Director, Radiation Oncology Services, FMRI, Gurugram, Dr. Swapna Mishra, definitively India's leading robotic gynecologist, Director Obstetrics and Gynecology at Fortis Hospitals, Mohali. Last and the best, my colleague from Bangalore, Dr. Monica Pansari, Senior Consultant Surgical Oncology at Fortis, Bangalore. It's a group of brilliant individuals, and we will try over the next hour to explore how technology has enhanced individual cancer care outcomes. So we'll start off with Dr. Pradeep Jain. Dr. Jain, the question to you is, how has minimal access surgery, whether it is laparoscopy or robotic surgery, improved care and outcomes in GI cancers?
Okay. First of all, Dr. Mohan, thank you for having me here. And about a question, first of all, I'll tell that I firmly believe that the cancer-related results, whether you do open surgery or laparoscopic surgery or robotic surgery, they are going to be same. It is basically very important in cancer patients to have an early recovery and less complicated recovery. So decrease the complications, like in minimally access techniques, whether you're using laparoscopy or robotic, the chances of complication, blood loss, and the overall inflammatory response of the body is less. So the patient recovers faster. And as well as because of the faster recovery or early joining of work, the patient has two advantages. That after recovery, the patient can undergo the adjuvant therapies as fast as possible, which is very, very important for their good results. And overall, because the patient goes home early, the overall financial benefit is also there for the patients, because in these kind of surgeries, patients have a lot of financial burden, and they have to spend money in a lot of areas, like whether surgery or a chemotherapy or radiotherapy or to overall improvement. So in those areas, if you go for the minimally access surgery, we definitely provide these two great benefits to the patient. So you are mute. Dr. Mohan, you're mute.
In summary, Dr. Pradeep, minimal access and whether it be lab or robotic preserves the outcome and enhances the recovery and enhances quality of life subsequent to surgery. Now, going across to Dr. Vedant, how has minimal access surgery enhanced outcomes in surgical oncology?
Now you're not audible.
Can you hear me now, sir?
No, I can hear you, but I think you cannot hear Vedant.
Dr. Vedant, can you hear me? Okay, we'll go across to Dr. Swapna. Dr. Mishra, how do you think robotic surgery has enhanced the ability to treat gynecological cancers?
I think robotic surgery for me in my practice has been a revolution. Like when you do a gynae cancer surgery, what we used to do like 5 years back was operate on a patient, keep the patient for at least 3 to 4 days in the hospital, and the patient would go through a whole process of a slow recovery over a period of next 1 to 2 months. You do the same surgery robotically with the advanced and better enhanced skills. You do sentinel node mapping, and then you send the patient next day morning home. Like in 16 to 18 hours, the patient walks back home. And in case, in some patients who are like local, we have been able to send the patient back home the same day. I think this is a total game change. If you can do a complex surgery causing minimal pain to the patient and a very fast recovery, and with a lymph node yield which is much better than any of the modality which used to do before, maybe a laparoscopy or open surgery, I think this is something which is there to stay and which is going to improve. And this is something which has made a marked change in the management of cancer patients.
What aspects of robotic surgery do you think has enhanced this ability to be nearly painless recovery with minimal use of analgesics, as well as provide greater precision? What are the aspects on the Da Vinci robotic system? You are a leading expert in the area of gynecology in the country with possibly the largest volumes. What does the robot provide which enhances recovery?
See, I think the when you have the robotic ports which are very stable. So when you're doing a laparoscopic surgery or an open surgery, you're causing minute tears or major tears in the peritoneum, which causes a lot of pain. When you're doing a robotic surgery, the ports are almost stable. So the multiple tear to the peritoneum which happens during surgery, which can cause the pain to the patient in the post-op period, is minimal. Number two is that if you see the transmission or the lateral spread of the energy when you're using a cautery device via Da Vinci robotics, what you find is that lateral spread of energy is minimal as compared to when you're doing the bipolars and a laparoscopy or when you're doing an open surgery, which causes less ischemic damage. So I think that these are the two reasons which are providing a fantastic pain-free outcome to the patients. And of course, because of that three-dimensional view and a 12x zoom view, your surgery becomes very precise. You rather go to the point and do the surgery rather than dissecting through various planes and trying to reach that point. Because of that good view and the three-dimensional view and the zoom view, it I think makes the surgery much more easy and easily accessible for the surgeon and also a better outcome to the patient.
And most important of all, for an older person like me, you can sit down and do. And the fact that the camera is under your control, not your
Yes.
assistant, makes it a auto navigational tool where your skill is all that is required and the passion to provide the best possible outcome. Dr. Vedant, can you hear me? Dr. Vedant, can you hear me, sir? Uh, Dr. Anil Kumar Anand, going across from surgical specialty to
Am I
radiation.
audible? Let me first check. Am I audible?
Yes, sir, you are.
Okay.
Uh,
Yes.
uh, Welcome, Dr. Anil Kumar.
Thank you.
Going across from the surgical enhanced by the robot practice of cancer, MR Linac is a breakthrough device. Question number one: how does it differ from conventional radiation treatment? And what specific advantage does it offer to a patient of cancer who needs this treatment?
So, thank you, Dr. Mohan, for organizing this small symposium. We installed MR Linac and started our first patient in August of last year. And so, your first question is that how it is different from the existing linear accelerators. So, most of the existing linear accelerators are CT scan based, and the CT scan which these accelerators have is cone beam CT, contrary to the fan beam CT which we have in diagnostic radiology. So it means the image quality in linear accelerators, even with the CT scan or the cone beam CT scan, is not as good. So why we have those is for kind of ensuring the accuracy of the treatment rather than precision. So we check that everything is in place. The organ to be treated is in place. The head is in place. There are no major shifts. But when we want to see the intricate anatomy, we cannot see on the CBCT scan based linear accelerators. In MR Linac, it is just the opposite. Here we have a diagnostic quality MRI, and it is 1.5 Tesla MRI, installed in a machine which also has a linear accelerator. So it is a hybrid technology. So it provides a big breakthrough in the sense we can visualize the tumor that much more clearly, whether it is a small tumor on the soft palate, or a tumor in the pancreas, or a tumor in the prostate. We can see that much, so much clear, that we can easily make out where is the tumor, and we can target it that precisely. Second, the advantage of MR-Linac is adaptive radiotherapy. So this has come into being in the last 3-4 years. Adaptive radiotherapy means we are adapting the radiation beams and the radiation treatment daily according to the change in the position and size of the tumor. So tumors move with breathing, tumors move day to day. For example, prostate tumor moves with the amount of gas in the rectum or bladder filling. So this is where we can do an adaptive radiotherapy, and we can precisely target our radiation to the involved site. So this is the basic difference between the existing Linacs and the MR Linac which we have. The second question you asked me, how it is helping us. So at this moment, I would say that the worldwide use of MR Linac is increasing, and at the moment there are about 80 MR Linacs in worldwide. However, this is only second in India, which we have here at Fortis Gurgaon. So it has been of great use in prostate cancer, where we are all the time we have a kind of uncertainty about the bladder dose and the rectum dose. So once we have an MRI, we visualize prostate daily on the MRI, we adapt radiation daily on the prostate. So that much side effects are markedly reduced to less than 3% compared to around 10 to 15% we used to see with a linear accelerator. Similarly, in pancreas, now there are multiple studies which are showing an improved survival because MR-Linac is able to deliver a precise radiation in inoperable or borderline operable CA pancreas who are not operable straight away or are inoperable. In head and neck, it has reduced the incidence of long-term problems in eating, dysphagia and the xerostomia. So it has great potential for improvement in the tumor control as well as reduction in the side effects associated with radiation.
So, Dr. Anand, tumors can run but can't hide with the MR-Linac.
Yes.
So,
nowhere to hide.
Yeah, nowhere to hide because they will be found out by the MR-Linac as a weapon for the radiation oncologist.
Yeah.
Two subsequent questions. Is there a great cost differential from conventional radiation therapy? Number one. Number two, is the duration of the therapy same as conventional radiation therapy, or is it shorter?
Yeah, I think a very important question. The cost of therapy is, if we consider, say, for example, in some tumors, we have to use the conventional fractionation of about 6 weeks or 4 weeks, then the cost is about 2 times. That is roughly the cost. But the second question is more important, and that is hypofractionated radiation. It means, for example, in prostate, we are coming from 20-25 fraction to about 5 fraction SBRT. SBRT means stereotactic body radiotherapy, which is curative for prostate cancer in just 5 days. You just patient is brought in, we plan, and radiation is delivered over 5 days, and the treatment is done. And this kind of SBRT is coming up in many organs. For example, pancreas, we are doing SBRT, not the conventional fractionation anymore. In the spine metastasis, we will do just 3 days SBRT in spine metastasis. So in oligometastasis, as we are now embarking on a journey of oligometastasis in many sites, we just finished treatment. For example, a liver tumor, we can treat in 3 to 5 days, metastatic tumor in the liver, with very minimal toxicity. So your second question, that the duration, yes, with MR-Linac, 20 to 30% of the patient we are treating with SBRT, where the treatment duration is just 3 to 5 days.
Absolutely the point that I wanted to make. In my own practice, when offered radiation as a solution and offered a treatment which is shorter with less side effects, it becomes more palatable to the patient, especially if the patient is an international patient or a patient has come from out of station to the location where an individual practice. That's a phenomenal new advantage from the perspective of radiation oncology.
Yeah.
Dr. Vedant, can you hear me?
Yes, I can. Can you hear me?
Thank you, sir. So,
Easily.
the question to you is in continuation to the ones I had asked Dr. Jain and Dr. Swapna. How has robotic surgery transformed your practice to enhance outcomes for an individual patient of cancer?
So I think they have answered this question already quite well. So enhancement of quality of life, yes, and Dr. Jain did mention that oncological outcomes may not be different. Although in some surgeries now it is shown that the lymph node yield is slightly higher with robotic surgery as compared to the other two modalities, laparoscopy and open. But oncological outcomes have not changed. What has changed is quality of life, their recovery from surgery, their return to work, less pain in post-op, and of course it is better for surgeons also because you get better magnification, better instrument movement, more degree of freedom in instrument movement, and precise surgery as a result.
The question to both, all three of you, more to Dr. Vedant and Dr. Pradeep is, do you use ERAS protocol? Has it made a difference to bowel recovery?
So actually, we had been using ERAS protocol previously, but we have found certain things are not that much important. We are using just part of that. Like we are, giving the glucose load in the day of surgery, and we are preparing patients with a mechanical bowel preparation only in left-sided colons, not the right-sided colons. And as such, we are using less and less of opiates, and we are using epidural anesthesia. These are the only things we are doing for the ERAS protocols. That's the things we are not following much.
So I agree because we are also using these only. It involves three teams: our team, anesthesia team, and critical care team. So all of them have to get involved to follow it completely. But these are the things that we are also following. And thankfully now the carbohydrate drinks are available in India, which were not available earlier.
Absolutely. That is the point I wanted to highlight, that it is still a team game between the surgeon, the anesthetist, and the post-operative critical care team. And although robot has enhanced magnification, manual dexterity, ability to filter tremors, to be precise, reduce pain, the problem of gut recovery has delayed the complete benefit of robotic surgery in an individual patient. And
Right.
ERAS, or for the audience, enhanced recovery after surgery using carbohydrate loading, lesser analgesics, has enhanced robotic surgery recovery. Just wanted to focus on the fact that the surgeon has two players always to enhance outcome. One is the anesthetic colleague and one is the critical care colleague, who are not involved in this particular symposium but are essential to ensure surgical skill actually translates into practical outcomes. Going now to Monica G. Dr. Monica, what is HIPEC? It's an acronym used across across specialties. What is HIPEC, and where do you think it has made an impact in improving outcomes for a cancer patient?
Thank you, Dr. Mohan, for having me here in the panel. Yes, HIPEC is a terminology which we call it as hyperthermic intraperitoneal chemotherapy. It has been used more often these days. Cancers which were considered incurable, or maybe where there was a limited peritoneal spread. It started with ovarian cancer, which usually has a tendency to spread towards the peritoneum, along the peritoneum, colon cancer with limited peritoneal spread, pseudomyxomas, appendiceal mesotheliomas. These are the cancers where we use HIPEC. HIPEC is basically a treatment where we are using chemotherapy at a higher temperature intraperitoneally. But first part of it is always cytoreduction, wherein we remove the disease completely from the abdomen, which is grossly visible. So we do first part as cytoreduction surgery. We considering I mainly deal with gynec onco, so I do quite a lot of ovarian cancer surgeries wherein We do complete cytoreduction, including total peritonectomy. Following that, we infiltrate chemotherapy at a higher temperature, that is 41 to 42 degrees Celsius, intraoperatively during the surgery itself. That is what is the treatment we offer for our patients with limited peritoneal disease these days. So it's been used quite often these days for ovarian cancers, colorectal, gastric cancers, mesotheliomas, pseudomyxomas. These are the indications where HIPEC is used these days, with a very good outcome and better overall survival.
Thanks, Dr. Monica. We move on to Dr. Sandeep. He possibly has the most expensive device that has enhanced cancer care, especially in brain tumors. Dr. Sandeep would want you to elucidate what is Gamma Knife and how has it enhanced individual patient outcomes in brain tumors.
So, firstly, I must correct you. The most expensive tool is with Dr. Anand. And all it is more expensive than Gamma Knife.
I stand corrected, but Dr. Anils is an old toy. You are the new kid on the block. You are in production. So yes,
Gamma Knife is a tool to provide a very precise radiation. Generally, it is called radiosurgery. So it is an alternate to surgery where you give a very high dose focused radiation to the brain, and typically the treatment is done in one session. In few larger lesions, we can, or where the treatment duration is very long, we can do it in multiple sessions. The Gamma Knife has been around for many years. What we now have is the latest version of Gamma Knife, in which we can fractionate the treatment also, because it has an inbuilt CBCT. So it has come as a great benefit for metastasis patients. It is particularly good for metastasis because we can treat multiple metastases all in one go. So a few months ago, we treated a patient with 56 brain mets in one go. And the patient had one large metastasis, which we operated, and rest of them were treated by Gamma Knife a week later. And now 3 months later, when we did her MRI, most of the lesions have actually disappeared. Similarly, we treated 2 patients with 28 and 25 meds, and we have treated many patients between 10 and 20 meds. And this is a one-day treatment. Patients generally tend to do pretty well. They can go back to their work within a day or two. And so it is an amazing tool for treating these tumors.
So the follow-up question from my own perspective is, has Gamma Knife a role beyond brain tumors? If so, in what cancers?
So Gamma Knife was designed only to treat brain lesions. It can go up to C2, C3 level. It can go generally up to C2. Only yesterday I treated a paraganglioma, which was going up to C2. So we could comfortably treat that. But beyond that, you cannot get that kind of accuracy with Gamma Knife. So it was designed only for brain.
That's a very important take-home message, because most of the maligning of the Gamma Knife outcomes has been in non-brain tumor usage. And I wanted a leader in the field to put that postulate across, that Gamma Knife is specific for utilization of brain tumors and should not be used unless there is a very specific rare indication elsewhere. Going back to Dr. Pradeep, what are the advancements as of today?
Can I ask a question from Dr. Sandeep? Dr.
Sandeep, yeah, please.
How Gamma Knife is different than the SBRT?
SBRT is a totally different thing. Like SBRT is for body, right? And we use SBRT for spine metastasis many times.
This can be used for brain metastasis also, no?
Like then we call SRS, stereotactic radiosurgery.
Okay.
So we were doing it on our equipment, which is Access machine by Electra. So for last 10 years, we were doing on that. And by and large, it does the same thing, but overall Gamma Knife is more accurate, gives less radiation, because there are 192 radiation sources which focus on one point, as compared to LINAC-based systems where there is a one radiation source which rotates. And because here there is no movement of the patient, there is no movement of the radiation source, while in all LINAC-based procedures, both the radiation source and the couch move. So there can be inherent errors of accuracy. So here nothing is moving, so the accuracy is much more.
So that's what the basic point was, teasing Dr. Anand, that the tumor can run but can't hide. MR Linac and Gamma Knife both provide that extraordinary precision to overcome artifactual errors in precise delineation of the tumor because of movement either of the patient, because of respiration or other reasons, or of the anchoring table that the patient is on. Coming back to Dr. Jain, in 2025, what are the advancements in minimal access GI surgery that have allowed you to offer a better outcome to your patient?
Yes, this is the majority of the innovations and developments are being in the robotic platform only. Actually, now in robotic platform, we used to lack the tactile sensations. Now, coming with the more and more better and better robot systems, like we are having a fifth generation intuitive Da Vinci system, which is having the facility of tactile sensations, as well as now, because it's an absolutely digital platform, so we can add a virtual reality and a augmented reality into the system, so that we can have better training and better educations for the surgeons, as well as with the navigation, good navigation with the augmented reality, we can have a better surgical outcomes and lesser damage to the surrounding organs. These are the things which are being developed in robotic system. And moreover, now AI is being incorporated into the robotic instruments. Like the best example is the staplers. Now they're using AI in performance of the staplers, so that they can have a better calculations while they're pressing the tissue, and they can come out with the answer that whether this tissue is too much thick or this is adequate for the anastomosis. So these are things which are being developed in robotic platform. I think they're going to help surgeon and better outcomes.
Absolutely. Sure form staplers have transformed bowel surgery. All of us, including large teams which used robotic surgery for bowel, whether it be intestine or use of intestine in urology, we were all depending on the lap port staplers. And with sure form coming in, as you rightly say, the accuracy and the ability to staple and prevent leaks is remarkable. The cost has also come down over the last few years to make it compatible or equally costly as the lab staplers. Going to Dr. Swapna Mishra, sitting in Mohali, operating in Delhi, telesurgery, robotic surgery. That's one way you can reach 100. Where do you think it is right now?
Yeah, we are not approved for doing any telesurgery, but I think that is something which our country should look forward to, because we don't have so many robots at various remote centers, and providing this kind of advanced technology to even the remote access areas. But provided we have a trained surgeon bedside of the patient, so that if the system fails, of course, it is internet based and power based. So if such a system fails, at least the bedside surgeon can take care. If there is an approval by the government and all, of course, maybe in the near future we can start doing this thing telemedicine, as we are already, COVID made us start telemedicine and those treating the patient online. So I think this telesurgery is almost there. It is just that we are waiting for the right protocols and right way in which we can take it forward. And with less number of robots in India and more, and our population being so high, I think this is the time where we have to explore in this area. Telesurgery is something which will really help the country.
Dr. Anil Kumar Anand, what is precision radiation therapy and how has it enhanced patient outcomes in radiation therapy for cancer?
So the term precision means how accurately we can deliver the highest possible dose to the tumor. Most of the tumors have dose response relationship. So as we raise the dose of radiation to the tumor, there should be better and better tumor control. So when we achieve precision, we can raise the dose. And for example, in pancreas, Dr. Pradeep must be operating pancreatic tumor. So in pancreas, we have seen this dose response relationship very well, that previously we couldn't deliver with the existing systems a dose more than 40-45 gray because of the proximity to duodenum, the stomach, even the kidneys and all that. Now with the MR Linac, we have already done, I think, 4 pancreatic patients, and we could deliver up to equivalent of 54 gray. So this could be achieved only because of the improved precision. Otherwise, if the collateral dose goes to the stomach and duodenum, we have to stop at 30 gray, 36 gray radiation. So The advanced technology helps us to target the dose, give a hike in the dose, and at the same time, when we are achieving such a precision, even the less side effect because of lesser collateral dose to the normal organ surrounding the target area.
Thank you, sir. So, Dr. Monica, the question is the World Cancer Day's theme was United in Unique. How does it
Yes.
apply to your preferred area of breast cancer?
Yeah, so UICC has declared for next 3 years the theme for World Cancer Day, United by Unique. So what does it mean? Basically, for as far as breast cancer is concerned, not only for breast cancer, basically for all the cancers, the treatment journey is unique. So this is focused towards patients or person centric approach. Every individual cancer patient's treatment journey is completely different. So is their treatment evaluation, treatment protocol, their follow up protocol, everything is different. So as far as breast cancer is concerned, every breast cancer patient's treatment is completely unique, completely different, and completely personalized with the evaluation, with the kind of uh, uh, evaluation we do. It becomes completely personalized approach for their treatment. Many patients nowadays we are seeing in early stages as well. So we are going more and more towards breast conservation surgery, which we used to do radical from radical to modified radical to organ conservation, and now we are focusing more and more towards best cosmetic outcome in cancer patients, especially in breast cancer patients, because these are the patients who have the best outcome, best survival rates if they are detected early. So what United by Unique, as far as breast cancer is concerned, we offer our patients the best cosmetic outcome if they come to us in early stages using different reconstruction techniques, whether it's oncoplastic reconstruction, local oncoplasty, or flaps which we use, or implants which we use. So we discuss with every patient differently what is best for their treatment outcome or best cancer treatment outcome along with best cosmetic outcome. So we've been offering nipple sparing mastectomies, skin sparing mastectomies. So these are the different operative techniques which we've been offering for our patients these days, depending on their evaluation and their choice of treatment, depending on the stage and type. So this is what I would say that.
You can uniquely treat a patient of breast cancer based on the individual characteristics to optimize their recovery. Dr.
Yes.
Swapna, what are the gynecological cancers where the intervention of the robot as the medium for surgery has resulted in measurably better outcomes?
All cases of cancer endometrium, we have been doing all such cases robotically. Secondary debulking surgery of cancer ovary, where the patient has taken a neoadjuvant chemotherapy, that is also we have been doing robotically successfully. Stage one cancer surgery, where the cancer ovary, where the lesion in the ovary can be taken in an endo bag, is something which also we have been doing robotically. CA cervix, we are not doing it robotically because that is not approved. So in all cases of cancer endometrium, 100%, secondary debulking 100%, which we are doing robotically, and we are having a very good outcome. The best part is that discharging the patient very early from the hospital, going faster ambulation, least requirement of any painkillers is something which has really helped us. And especially in cancer endometrium, with the advantage of robot, we are doing a lot of sentinel node sampling, that is ultra staging, which is
I was
helping
just
us.
coming to that. Would want you to elucidate on how ICG and sentinel node sampling has provided a far better outcome to patients of endometrial cancer.
So, in case of cancer endometrium, what we do is that we inject the cervix at 3 o'clock and 9 o'clock position with ICG, and that maps the lymph nodes which are most likely to be involved by the transfer of the cancerous cells. So, once we go under the robotic view and switch on the firefly, these areas they turn green. They become fluorescent green. So it becomes very easy to remove the sentinel node and send it for the frozen section for ultra staging. So if sentinel nodes are positive, then definitely the patient is a patient for a chemoradiation. If the sentinel node is negative, then in that case, a further the patient is safe. But for a person to be very expert in sentinel node mapping, you have to first at least do 30-40 sentinel node mapping along with the entire pelvic lymph node sampling, just to see that your sample of the sentinel node is very, very accurate. So with the sentinel node mapping, at least the complete pelvic lymphadenectomy is not to be done. And that also brings down the morbidity on the patient, because when you're going lot into the obturator fossa, you're going lot onto the iliacs, naturally the complication also starts going up. So this the advantage of ICG along with the Firefly has made a lot of difference in the management of cancer endometrium. Few centers in
Absolutely.
US have started even using ICG and injecting into the pedicle of the ovary, just to see which node will get positive in the paraotic area. So that is something we have started exploring, the use of ICG in case of cancer ovary, where we want to see which node might be draining that particular ovary, and we take out that node and send it for ultrastaging.
Basically, you will correctly treat 3 patients, and you don't trouble the remaining 7 who don't need it. So
Who
you
don't
have
need
the
it.
choice of ensuring complete cure, and at the same time ensuring that you don't do extensive lymphadenectomy in those who don't need it.
Don't need it. Very true.
ICG, ICG and Firefly are extraordinary part of robotic surgery. Coming to Dr. Sandeep, what are the specific brain tumors where gamma knife has been a game changer?
Uh, Gamma knife initially was used for benign lesions like meningiomas, acoustic tumors, and it was pretty good for these tumors because a small tumor you can easily treat it with gamma knife and patient can avoid a major surgery. And it has also been used for residual disease when you have removed a big meningioma and some disease is left in the sinus, or in acoustic when some disease is left in the canal or along the facial nerve, and then you can easily treat that with gamma knife. Gamma knife has also come as a huge boon for AVMs. A lot of these AVMs are inoperable and situated in a critical location. And with gamma knife, they just disappear without any trace. So it has been amazing for AVMs too.
A question for both Dr. Pradeep and Dr. Vedant. Do you use a drop-down robotic ultrasound probe? And if yes, where do you use it, and how has it transformed your practice?
No, I'm not using it right now.
I'm also not using. We don't
For
have
us
enough.
in for us in urology, the drop-down probe has been a magical tool
For you,
in
partial nephrectomy, I think.
partial nephrectomies.
Yeah.
And I thought in HPB surgery again for deep placed liver tumors, it could help. I just wanted to pick your brain on whether it is being used. But it has transformed partial nephrectomy with the BK drop down robotic ultrasound probe. Now, going back to Dr. Monica, do you believe that mastectomy is the choice of treatment for every newly diagnosed cancer? And if so, what would be
Everything right
the
here,
technique of reconstruction?
एकदम से कम हो गई.
So that's the question most of our patients they ask, sir. So nowadays, mastectomy is not the treatment of choice for most of our patients. We try to evaluate patient as far as possible. We offer them breast conservation surgery if it is oncologically safe. Uh, what does that mean? That patient should come first in early stages of cancer. Early detection is the most important prerequisite. Most of our patients are coming in early stages these days, especially in urban areas. Few are coming in advanced stages where we need to offer them mastectomy. And if we have to offer mastectomy, we discuss the pros and cons, and offer them immediate reconstruction. So different forms of reconstruction, different types of reconstructions, which we offer depending on the patient's choice, patient's medical condition, their financial status as well. So depending on that, we offer the reconstruction options. It could be as simple as latissimus dorsi flap with implant, without implant, or a free flap like DIP flaps. So these are the different kind of reconstructive techniques which we offer our patients post mastectomy. So to answer the precise answer to your question is that no, not all the patients they need to undergo mastectomy. We are moving more and more towards breast conservation, that too with the best cosmetic outcome, even if they have to undergo mastectomy. So reconstruction is a norm these days. We offer to all our patients. So their quality of life, their emotional well-being, everything is well taken care of in recovery, because they are the ones who are the long-term survivors as far as breast cancer is concerned.
So this is a question to the whole forum, and this is what Fortis has been a benefactor in enhancing our practice, whether it be in adaptation of Da Vinci robotic system, or in MR Linac, or in a gamma knife being procured and made available so that we provide the best technology in providing excellent outcomes to the patients who come in trust to us. Now, each one of you, the question is what technology in your individual specialty in 2025 would you want Fortis to bring in that could enhance the patient outcomes in your practice? I would go with Dr. Vedant first and then take it forward from there.
So if technology is concerned, then I think some attachments for robo, and our robo is now nearing its life, so maybe we can have a fifth generation Da Vinci, along with MR guided biopsy systems, which are very far and few even in the country as a whole, and we do require them for certain breast lesions. I think these are the two which I would like Fortis to have in our center.
We already have a MR fusion, and we possibly are the largest practitioners of MR fusion biopsy. But I
Yeah,
agree
that's
with
for
you.
prostate. That's for prostate. For breast, there is a slightly
Agreed.
different.
But that is a technology I think will enhance your practice. That is where I was coming. It has enhanced the practice. We got the equipment as a special CEO's grant 3 years ago as an experimental tool, but it has remarkably transformed our ability to diagnose clinically important but missed on previous conventional biopsies. Dr. Pradeep, what is it in your book that you would want Fortis to procure that can enhance your patient outcomes? Dr. Pradeep? Dr. Anand, what is it that Fortis can provide?
I would say we were quite fortunate to have one of the, I would say, one of the very sought after technology, MR Linac, which I never thought India will have so soon. So my hands are already full, and I don't need anything more in 2025.
You're the only
We
happy gentleman in the symposium.
Yes, yes. We want a good MR Linux symposium to highlight what all we can achieve with, and we are growing slowly in MR Linux. Each day we have few surprises and few things to learn. And other than that, we also acquired surface guided radiotherapy to improve accuracy in other Linux, and a better brand of treatment planning computers. You know, all our radiation is planned on computers, AI assisted computers. You must have heard about a lot about AI these days. So there are a lot of AI assisted computerized treatment planning system we already have, and one we have already installed with MR Linux. So we are quite fortunate to have most of the things in-house here, and maybe we upgrade our facilities in rest of our Fortis hospitals. For example, Mohali should upgrade, I feel. And yeah, Dr. Swarnaj, you can convey that they need a better accelerator with better image guidance. You lend your support and converse for them. They will have soon a very good department. So other than that, I think other hospitals, for example, in Delhi NCR, we want to reach to other centers. But we are fortunate; we have plenty here at Gurgaon.
So neurosurgery, radiation oncology at FMRI Gurugram is a happy ecosystem. Dr. Swapna, what is in your wish list?
Wish list, if the Fortis doesn't bother about the finances, is something. I love the robotic surgery, the platform, but only thing I don't like the scars. Even if there are 4 holes, if I could just go for a single incision robotic surgery, have that single incision one through which I can do all the surgeries, I think that would be something I would really love to have in future. I think that won't be so. Hospital always thinks of a system which can be used by all the doctors, all the surgeons in the hospital. But this is something which is in my wish list. So suppose hospital says that what do I want is I want to go for a cosmetic gynae surgery where I can do all the surgery including malignancy through that single hole. I think I would love that part. Hello?
Hello?
Hello, am I audible? Hello?
Hello?
Hello? System hang.
Hello, I can hear you, Dr. Swapna. I think,
I think Dr. Keshavamurthy has logged off,
Yeah,
probably.
so
Some connection issues.
fine. So this is something which I would have wanted for gynecology. At least, we are progressing from multiple incision to single incision, and women need lesser scars on their belly. So I think that is something I would have really loved to have, if I'm allowed for it. Otherwise, DB5 is something which will help all of us in the hospital.
and
That's right.
Dr. Vedant will agree with me that we are more, focused on the functional results actually. So I'd like to have a intraoperative ultrasound center, which is not there. I've been asking for a very long time and not getting it. And as well as for the teaching purposes, we should all have dual console system.
Yes.
Yes.
I don't think any of
I
the
totally
centers
agree.
having a dual console.
Mhm.
Do you have
Yeah,
a
no,
dual
there are
console?
centers which have. So Tata Memorial in Mumbai has that.
No, but in the Fortis system, I don't think
Yeah,
we
in the
have a
I
dual
don't think
console.
we have it. Yeah, we have. I don't think we have it. So yeah, Dr. Mohan had also asked about what are the things that we should our patients should know about in surgical oncology advancements for 2025. And Dr. Monica did mention about breast surgery, but then there are other things as well. So the theme now has become de-escalation in oncology. Also, surgical oncology, radiation, medical, all three specialties. And we talk of less and less surgery giving more and more outcomes. So from maximum tolerable treatment to treatment which is minimum and equally effective is what we move on to. So from breast conservation, we are pushing the limits for conservation. Extreme oncoplasty is being done for larger and larger tumors. Sentinel lymph node biopsies being done even after chemotherapy, where nodes were positive and limited positive node, and they have turned negative on chemotherapy. In fact, for very early cancers, very favorable biology cancers, now there are two big trials which have shown that sentinel node biopsy also can be omitted. So don't even need to touch axilla for certain tumors. And this is one spectrum. So de-escalation. On the other side, we are going more extensive. For example, HIPEC that she mentioned, PIPEC, doing surgeries for metastatic disease and giving them better outcomes thanks to better systemic therapy which is available, which can control the systemic disease in a much better way. So there are many tumors, for example, breast, colorectal, even sarcomas, where for oligometastatic disease we are able to offer surgery for metastatic sites as well.
Thanks, Dr. Vedant. One take-home message from each of you for patients who are suffering from cancer out there or their loved ones. One take-home message, starting with Dr. Swapna.
Take home message is we can treat you, we can cure you, we can provide the right kind of technology, the best technology, what you can get in any place in the world. We can provide to you at Fortis, and we all are equipped with all the technology through which we can make you go through the cancer process very smoothly. So trust us.
Dr. Anil Kumar.
My message would be we are here to take you through the journey of treating a cancer. So if a patient comes to me, I will try and take him or her through the entire gamut of treatment so that we can guide her at different spots what to do next. Remain care and guiding the whole journey of treatment of cancer.
Dr. Pradeep.
Yes, regarding, I just want to give a message that regarding cancer, the surgical results of the cancer is important, but simultaneously the early recovery and a comfortable recovery and a early back to work is very, very important for the cancer patients. So we provide this opportunity at Fortis Hospital with the help of laparoscopy and robotic surgery. So one should avail this facility as far as possible, because if we go for these kind of surgeries in the long run, they are having less financial burdens as compared to the open surgery. So
Dr.
one should
Vedant?
use these facilities as far as possible.
So for patients, I would like to say that you should find a person and a place which treats you as a whole, provides the complete gamut of treatment, and it is not only surgical, medical, radiation oncology, but a holistic approach to cancer treatment, because there are certain very useful and often ignored interventions like psycho-oncology, dietary management, exercise, and all those things. So we must treat our patients in a more holistic way, and you must try to find a place which provides you with all that. And definitely, as Dr. Sapna said, don't fear about it. Most of the cancers, if they're caught at the right time, can be cured.
Dr. Monica?
Yeah, so I would say that my take-home message for all the cancer patients would be that try not, if the cancer is diagnosed, no need to get scared. Discuss all the treatment options in detail with your oncologist, all the possible options, and trust your doctor, trust your oncologist, because there are a lot of treatment options coming up. You'll get confused, but I would say that you should trust your oncologist, go through the journey, and again, a holistic treatment approach. It's not only about surgery, medical oncology, or radiation. It's a complete treatment which you should avail for, you should take for, and you should ask for that. This is what you are, and that's what we are doing in Fortis Hospital. So you should, as Dr. Swapna also said, you should trust your oncologist and then go ahead with the treatment journey, not to get scared. And most of the cancer patients are doing well with us. So if provided they are diagnosed in early stages.
So the take-home message overall after an hour of Manthan is that cancer can be cured, cancer can be fought. Patient centricity, collaborative practice, and the ability of Fortis Hospitals network across the country to provide an ecosystem where the latest technology has met with the best skilled clinicians to enhance individual patient outcome with precise treatment and minimal side effects. It was a pleasure to have all of you on this particular session. I understand and respect the fact you have spared time to spread the message that cancer can be cured, cancer can be fought, and it just needs an early intervention with appropriate skill and technology, with clinicians working with the patient as a whole, as put across holistically to ensure the patient and the family recover from the shock of being diagnosed with cancer. Thank you. Have a lovely evening.
Thank you.
Thank you, sir.
Thank you.
Thank
Dr.
you.
Mohan, thank you so
Sir,
much.
thank you very much.
Thank you, sir.
Thank you.